Hello everyone, I hope you can all hear me. If you can hear me, just make a comment. I think that uh, it's okay and we may start in seconds. I just want to make sure that everyone here can listen and see and everything is fine. The presentation, I think that it's okay. All right, it's clear. Thank you. Hello everyone again, and today we are going to talk about one of my favorite topics, retrieval protocols, to simplify the complex protocol, to talk about, all right, just 1 second, yes, everything's fine now, all right. Simplify the complex protocols of separated instrument retrieval and to move from the old protocols or even techniques or even instrument to the more conservative recent techniques and instruments. All right, let's start. As we already did talk in the last lecture about retrieval and the factors associated with broken file or separated files, and the factors related to the tools, the factors related to the instrument, the factor related to the operator and the patient also. From these important factors, we have to know again that in my protocols, if I have a broken file beyond the curve and I cannot see it, I will just go to the more conservative, which is bypass. But if I can see the file, if I can have a straight line axis, if the file is broken before the curve, I will just go to retrieval because it will be much more better, but with the right tools, with the right techniques, and indeed with the right hands. Before we start today, as I always say, stay safe, save yourself, your parents, your sons from the corona, and I have also to mention that I'm supposed to be, if there is no coronavirus or this era of coronavirus, I'm supposed to be today in Kielce, giving my course in Kielce in Poland, giving my course for the first group of attendees today. So I have to say that I really miss Poland. I really miss my friends there. I miss you, Tomasz. I miss you, Agnieszka. I miss all of you. And indeed, in the last Pulp Fiction, it was really great to be there with them. Here is some pictures of the last Pulp Fiction. Here is my friends. I really miss all of them. And here is my great guy. I really adore this guy and I really respect him a lot. And he is one of my idols to follow in dentistry. I really miss all of you. Now let's move to our topic today. As I already said, first, if I have a file or a separated instrument, in the coronal 1/3, we will have a different kind of management. If it's in the middle before the curve, we will have another kind of management. And if the separated file is in the apical area beyond the curve, because sometimes in the apical area it will not be beyond the curve. It may be in a big canal and you have a lot of dentin and you will not sacrifice a lot of dentin. With the right tools and with the right technique, you can remove it. So as I told you in the last lecture, I will just classify the separated instrument location into before the curve and beyond the curve. But This is the generalized classification, and we should mention it as like that. So, if the file is in the coronal third and it's very easy to catch it or to have an access to it, we will just or can use a hemostat, Stiglitz forceps, modified needle holder, or even berry pliers. We have some instrument or even hemostats or pliers that we can use in this part of the tooth because it's a little bit easier to remove files in such areas. And again, even if you don't have a microscope, maybe in this part of the tooth you can just with the loupe or with the right magnification you can remove the file. But let me tell you that if the file is a little bit engaged in this part, you will need some ultrasonic troughing, and with magnification you can decrease the amount of dentin that you will remove. So again and again and again, magnification is a must. Magnification when dealing with such advanced subjects or even such topics, magnification and good elimination is a must. Alright, I will just mention in a hurry these many forceps. We have Stiglitz forceps as I said. We have endo forceps also from Roydent you can use. We have a lot of forceps you can use in such part of the canal. Stiglitz forceps is a very famous one you can use. They are available in straight, angle 45 degrees or even angle 90 degrees to give you more handling. But I have to tell you that this kind of technique, this kind of forceps to remove the file will just work if the object is loose, not engaged in the canal, and also if you have a good access to it. So, because a lot of people break such instruments in the coronal 1/3 and then they ask me how to remove it, but they don't have a magnification. Yes, they will remove it. As I told in the last lecture, congratulations, you retrieve the file, but you killed the tooth. So again and again and again, magnification is a must. And if the object is not loosely fitted inside the canal, you will just need to make it loose a little bit, and you will just need the ultrasonic at that time. Alright, we have also this technique of braiding. When the girl braids her hair with headstrom file, H files, or even K files, you can just put 1 or 2 or 3 files to braid the instrument inside the canal and pull them all together. Just 1 second, please, because I have here, yes. Again. Thank you. All right. Let's go to our slide again. All right. And you braid these files together, engaging the separated file between them and pull the whole part together, and it may sometimes take this file with that. But in such cases, I use this technique if I only have a fragment which is very loose, deeper inside the canal, and I cannot have a direct access to the file, but it must be loose. So if I have, for example, a broken file or a separated file that during my separation it's a little bit pushed inside the canal in a deeper area that I cannot see or manage to take it out, I may use this technique. Alright, now ultrasonic. We have to mention ultrasonic today in our lecture because if we are going to talk about retrieval of broken files, we have to mention ultrasonic. Simply because According to a study by Dr. Madirati et al., they concluded that about 98.5% of endodontists in the United Kingdom, they use ultrasonic in their retrieval. So, ultrasonic is a must if you are going to retrieve files. You will need it, is a must. We have a lot of different tips, different angles, different lenses, different sizes, but you should know that the deeper the fragment is located inside the canal, the longer and the thinner will be the ultrasonic that we should use. But if you are going to use these long, thin tips, you have to decrease your power settings in the ultrasonic because it may break easily indeed. I have to mention also that the success rate of a fragment removal by using ultrasonic in clinical trials ranged from 67% by Nagy et al. To 88 and 95% by Koji et al. And Fu et al. So, from these all studies, we have a lot or a high success rate of fragment removal using ultrasonic. But in some cases, look, if I want to summarize what I use in my clinic, 90% of cases you will just use the ultrasonic, but the other 10% you will need another technique or another instrument to use. So ultrasonic indeed, we must need it even if you are going to use it with another instruments, but I have to tell you that not every case can be just removed with ultrasonic only. Alright, here is the normal steps. I will just mention it in a hurry. First of all, you have to have a good magnification and a good illumination. As I said, you have to see the instrument. So if you want to have this direct access, direct vision to the separated instrument, you have to make this staging platform, this circumferential staging platform. And as Ruddle mentioned that, if you are going to make the staging platform, you can just use the modified Gates-Glidden. You get the Gates-Glidden and with a stone you just remove the tip, so it will be a modified Gates-Glidden and you can use it. We have size 2, 3 or even 4, and here is the sizes of the Gates-Glidden burrs, but I was in the past using 1, 2, 3, 4. Nowadays, and I will talk about my protocol today, I just use 1, 2. Maximum, in some cases, I use 3. But honestly, with size 2, nowadays, it's a little bit enough for me. And then after that, I use another instrument and I will tell you about all of that. So, if you are going to use this Gates-Glidden or modified Gates-Glidden, a speed of 300 RPM with just light contact to the most coronal part of the file, congratulations, you have this you have this staging platform. So please try to make this platform centered as you can. So that's why some people nowadays do not use a modified Gates-Glidden and just use bigger orifice openers and even modified orifice openers. They can just clip 1 or 2 millimeters of the tip of the file of the orifice opener and use it to make this kind of staging platform. And then after that, you have to know that you need to use copious irrigation to remove the debris and the dentin shafts. Then after that, you have to dry. That's why we use this paper point so we can see to enhance the vision. After that, you will just select the good and appropriate ultrasonic tip and you will just make this troughing around the broken files, and we will just see and talk about if you are going to trough or to put your ultrasonic in the inner curve or the outer curve, because sometimes, as a general rule, we use it more in the inner curve. But sometimes if you have a long broken files or a longer file, and when you are going in the inside or the inner curve and make this troughing and the file does not get out because a little bit part of the file in the outer curve is still stuck there, and you need to remove a little bit from the outer curve, but you have to be cautious not to make a lateral perforation. And then after that, we have to talk a lot about the amount of coronal exposure of the file, because sometimes you will just with ultrasonic remove and refine a lot of dentin. You just remove in a counterclockwise. I have to mention that you will just use the ultrasonic in a counterclockwise motion, because most commonly the file is engaged in a clockwise motion, and this is not a rule. This is in most of the files, because some files or some instruments are just used in a counterclockwise. So in such cases you have to use clockwise. But as a general rule, or in most of the cases, you will just use the ultrasonic in a counterclockwise motion. And sometimes you just refine in a counterclockwise motion, but you just expose a lot of the file and the file does not come out. The file didn't come out. So how much of coronal exposure do you think is enough? And how much of coronal exposure is better? So we can remove a lot of dentin. Yes, you can just refine until you get the file loose, but you removed most of the virgin dentin. So that's why we modified a little bit our techniques nowadays. So we have this kind of diamond coated tips. Please do not use it because it's a little bit more aggressive. In such cases, just use the normal, ordinary ultrasonic taps. You should also know that you should touch the file, but keep this touching as little as possible. And also you must remove dentin, but also you have to keep much more virgin dentin as you can. In cases of fragment in long roots with limited access and the broken file is a little bit in a curved root, you can use titanium ultrasonic tips because it's a little bit flexible and you can just use it inside these kind of roots. And I have to mention again and again and again, blind refining is avoided. Blind refining must be avoided. If you cannot see, please do not play, because I know a lot of guys, and I will show you a lot of cases, just they refine blindly. They cannot see and just refine. Yes, sometimes they will just remove the file, but the tooth is completely lost. So please, blind refining must be avoided. And also I have to mention here that the nickel titanium and stainless steel respond differently to ultrasonic, because stainless steel can absorb the ultrasonic and can be removed easily, but the nickel titanium is different and it's a little bit brittle and break up easily. Alright. And also sometimes if the fragment is loose and I cannot go with ultrasonic, I can just use a K-file inside ultrasonic and use this K-file as a tip. Yes, but we must use this kind of endo shock, so it will just adapt the file inside it. But you have to know that we can use this technique only if the broken file is bypassed. And you will just use the file smaller inside than the one you used as a final one to bypass. For example, if you bypassed the broken file with K file number 20, you will just put K file number 15 in the endoshock and try with the irrigation, especially EDTA solution indeed, to ultrasonic vibrate the separated instrument and to go out. So if you are going to talk about ultrasonic, I have to mention that this device, Ultra X ultrasonic, is a great device. First of all, it's wireless. It has two kind of powers you can use, and they have the most interesting part is the tips. They have variety of tips, and the size of the tips is 2002. Can you imagine? Just like a K file number 20. These great tips are very conservative, and I'm using this device in my retrieval cases nowadays. So I had to mention this Ultra X before we are going to the next technique. The holding technique, the concept of this technique is to expose a little bit part of the coronal part of the fragment and use another instrument to remove the file. And this technique is good, but you have to know that among these holding techniques we have a lot of historical techniques, like for example the Maseron technique and a lot of other techniques, Mitrak endo safety and instrument removal system and endo rescue, and even we had this endo extractor system. We have a lot of holding techniques, but I have only to mention this Maseron technique because it was very, very, very aggressive inside a canal. Why? It consisted of about 14 three-fine pair with different sizes, and they have two sizes of of extractors, and these two extractors were very big, 1.2 and 1.5 millimeter. They were very big and aggressive inside the canal to remove an instrument. That's why this technique was just constructed to use it in anterior tooth, because if you want to use it, if you want to put the extractor, you will just remove a lot of radicular dentin. You will just remove a lot of dentin, and this is not conservative in any way to use. So, in the past, Maseron kit, yes, it was a good technique, but it was a very aggressive to be used. That's why it was only used in the anterior tooth or even in posterior tooth in a straight canals. But most probably the files will not break in straight big canals. Another technique is wire loop technique, and this technique is really great, and it was first described by Ruggreen in 1983. Here today, if you are mentioned this wire loop technique, I have to tell you that you can make your own wire loop technique. You can buy the loop and you can buy the wire, and you can use it inside any injection needle, 25 gauge for example, and you put the wire inside it, and with a hemostat you can have your wire loop device. But it's a little bit not reproducible in a reproducible manner and a little bit time consuming. For me, I use this great device. So from the ultrasonic technique, I said that I use Ultra X with these great tips. So now if I want to talk about a wire loop technique, I use this BTR pen. This broken tool removal from Circumid is a great tool you can use to remove the file. Sometimes we have this kind of long broken files, and just with some refining or some exposing of the broken separated instrument, just if you have 1 or 2 millimeter maximum of coronal exposure, you can just use the BTR pen, and they have a great lifting capacity. I know that there are a lot of wire loops or lasso inside the market nowadays, but you can just know that They have three kind of needles, 0.3, 0.4, 0.5, and the wire is less than 0.1 millimeter inside the needles. But I have to mention that the lifting capacity of the 0.3 is 1.5 kilograms, and the 0.4 is 2 kilograms, and the 0.5 needle tip, the lifting capacity of it is about 2.3 kilograms. Can you even imagine that it has a great lifting capacity you can use? And honestly, from the day I started to use the BTR pen, it's fantastic and very easy and very producible, and you can just use it in the daily practice of removing an instrument or separated instrument inside the canal. You can see here this file, it was more than 10 millimeters. It was about 15 millimeters. And just with 2 millimeter, as you can see, with just 2 millimeter of exposure, of coronal exposure of the file, I was able to remove the file. Alright. And here, as I told you, they have this kind of needles, 0.3, 0.4, 0.5. And by the way, 0.3 is the thinnest available in the market. And also the wire is a great intelligent material you can use, and it has a shape memory, and this wire is great and can really withstand a great forces in the lift during lifting it. I will show you a video now of this BTR pen from Circumed. Here is the tip, the needle. This video is from the company itself. You can just, here is how you put or you fit your BTR tip into the device. This is how you engage it. Alright, fine. And then after that, indeed, under magnification, you can just, yes, here is how they assemble it and how they engage it, and here is after. Under magnification, you can just remove the cover that protect the wire loop, and here is with a caliper. You can just calibrate your wire to be used inside the canal. Here you can see our wire loop, and also you can here bend it or adapt it to the canal if you have such kind of curvature inside the canal. Here we have a separated file inside the canal with a little bit go beyond the apex. That means that it's a little bit engaged inside the canal. And here is with the wire loop, it's a BTR pen. You can see here how we engage the file, and just with a little bit movement or vibration or hesitation, you can just remove it. Here in this video, because I can see that a lot of people asking about my protocol of retrieval, I will show you in this video how I remove the files in my clinic. Here you can see I have a file. Here is Bella Ciao. I have a file. I will just decrease the audio a little bit. I have a file inside the canal, and I made the staging platform with just gates glidden 1 and 2. And then, as you can see, I can see the file with the Ultra X steps, which is very, very conservative. I can make this kind of coronal exposure to the file. And then after that, indeed, you will just dry the canal with paper point. And here you can see I made this kind of ultrasonic troughing in a counterclockwise motion around the broken file. Mostly I do it in the inner curve, and then once I can have 1 or 2 millimeter of exposure to the broken file, I can just have the loop and use it. And believe me, this is the most conservative protocol I have ever made or I have ever did in my clinic up till now. Ultra X with the great conservative small tips, and then after that with BTR pen. This kind of protocol is very, very, very feasible, teachable, repeatable, as we always say in style Italiano. Endodontics, just ultrasonic troughing. In some cases it just go out, and in this kind of long separated instrument I prefer to make this kind of troughing with Ultra X and then to use the BTR. As you can see, it's very, very, very easy, very feasible, very repeatable, very teachable protocol to follow. So you can just remove the file, and you cannot remove a lot of dentin. This kind of retrieval protocol is very, very, very conservative. And as I said, you have to have this kind of balance. You remember the elephant standing on the bowl. You have to have this kind of balance in your mind. You have to remove the harm, remove the separated instrument, but also you have to save the tooth and do not remove a lot of dentin, because we have a lot of complications associated with the removal of separated instrument. Just for example, ledge formation. When we do this staging platform, as we said in the first lecture, ledge formation is very common because we did this staging platform, and then after that you have to go again to the main pathway of the canal, and in such cases, as I told you, here is the time for the great flexible Fanta AF F1 Blue file. And also among the complications that I had sometimes during retrieval is excessive root canal preparation, and that may, if it's in a dangerous area, it may cause strap perforation. And also sometimes the instrument that I used in removal, sometimes also it breaks. So please try not to use a lot of second-hand or a lot of used ultrasonic taps, and also, and this is very important, the risk of heat generation, because the ultrasonic just made a lot of heat. We have some studies talking about if the increase in temperature about 10 degrees, it will harm the dentin, and nowadays this trials or this conclusions is not anymore accepted, because 10 degrees above the body temperature, it will not make any harm to the bone and even to the periodontal ligaments around it. But as I said always, if you are going to use the ultrasonic, and indeed it will generate heat, so you can just cool down the whole system with your irrigation solution and dry again. It will just help you to cool down the area, to remove the debris, and to have a good vision. And also you have to know that sometimes even with all that, you can just extrude the fragment or push the fragment more in an apical direction. Now let's move to some retrieval cases, because I know that retrieval cases, it's a little bit more catchy, and the cases is the catchy part in any webinar or even lecture. Here we have a broken file. By the way, this file was high flex CM file, and it was broken in one of the canals in the mesial root, and it was a C-shaped case of lower second molar. As you can see, we had about 6 orifices, but we have only one portal of exit. Here we just remove the file, and as you can see, the canal where the file were there, just we remove the file, and then after that with Fanta AF F1 Blue, I was able to go in the main pathway and to again negotiate the main pathway of the canal, shape, irrigate, clean, and obturate, as you can see in this case. And in this case I used only ultrasonic, because ultrasonic in this case was only enough, was fair enough to remove the broken file. And you can see here the apical magic of the obturation. You can see here this kind of extrusion of the bioceramic sealer here in this case. Another case, we have here a broken file before the curve, and it was very, very easy to use. As I said again, the ultrasonic, and you can see how much conservative was the preparation. You cannot even see any kind of ledge or staging platform in this X-rays. It was really conservative, because in this case I used the Ultra X again from ETS. It was really great, and it just removed it very easily. And you can see here in the picture, I just grabbed it with this kind of tweezer, Zomax tweezer, and then I removed the file. Another case, and this case was a little bit not easy, because we have 4 broken files here. We had 4 broken files in the mesiobuccal and the mesiolingual of the lower second molar. And I was really lucky that the root is short. That's why it was not hard to remove. The amount of gataberca that the previous dentist, by the way, this case, the previous dentist referred it to me after he tried to bypass it. He did break the first file, and then he tried to bypass it. He did break the other file, and he tried to bypass both of them from the other canal, because the 2 canals are opening together, and he break another one, and then he tried to bypass it again, and he did break the 4th file. He did break 4 files, and this is normal. We have all such cases of file separation. It was not his lucky day, and then he referred the case to me. I removed the gataberca because he did put obturation, and he waited for the follow-up, and the patient didn't feel good, and the pain is still there, and the signs and symptoms were there, so he referred the case to me. I removed the gataberca, and then I have a great direct access to the broken files, and with the Ultra X steps, which is very small, I was able to, yes, these files are beyond the curve, but the beginning or the coronal part of the file, I can see it. I didn't remove a lot of dentin. I just removed the gataberca, and I was able to see these files without removal. This kind, it was just, I did the coronal preparation, or the staging platform was Getzigleiden number 2. I didn't remove a lot. I didn't remove even anything except gataberca, and I was able to see the file. So with ultrasonic Ultra X step, I was able to just make some troughing in the inner curve, and the file started to jump one by one until I removed the 4 broken files. And then after that I used the Fanta AFF1 Blue, and you can see in the X-ray deep, you can see it was a little bit S-shaped, and the Fanta AFF1 Blue was able to negotiate the second curve and to take it and to shape it. And then after that I irrigate and obturate. Another case here, it was not easy at all. Here is a second premolar, and we have 3 broken files, and also the previous dentist tried to bypass them, and he break one and then tried to bypass, and then the third one, and the portal of exit was a little bit closed, and then he tried to bypass again, but he made a perforation. Then he referred the case to me. I hope that all my friends refer the case to me when they have the first file broken, because they made a little bit more difficult for me to remove after that. Anyhow, the patient was epileptic, and it was not easy to use and to retrieve the files, and also the premolar had this kind of mesial angulation, and it was not easy also to see the files or to have this kind of accessibility to the file. And then once I can see the files, I use the ultrasonic also in the inner curve, and a little bit 1, 2, 3. The 3 files were just moved outside of the canal, and in the last step you can use EDTA solution to help the broken file to be removed from inside the canal. I think that you all know that. And then after that I just obturated this perforation and the other part or the main pathway of the canal with NTA. And then I injected the cerebroblastized gataperca, and we have a great follow-up for this case up till now, touching wood. Alhamdulillah. Thanks, God. Alright, we have another case here. You can see the file, part of the file is beyond the apex, and this is lower second molar, and the file was a little bit make some pressure on the inferior alveolar nerve, and from the day this patient made this kind of bad obturation, she had a little bit some kind of numbness, and I decided to remove the file. But in such cases, ultrasonic only will not be right to be used, because you are afraid of harming the tissues beyond the file, or even push the file more deeper. So in this case, I removed the file with I made the staging platform with Gates-Gladden and ultrasonic troughing without touching the file around it, and then with the lowest power on Ultra X, and then with the wire I removed the file. And here you can see the file when I removed it, patency, master cone, and here is the obturation. And once I removed the file, once I made the obturation, once the anesthesia went out from the patient, she felt no more numbness, and it was very pleasant for her, and she thanked me in her own way. Anyhow, we have also another case, retrieval case number 6. Here we have a broken file, we have a short obturation, we have missed anatomy and the distal root, and bad obturation also in the distal root, and we have ledge, we bypass the ledge, we have broken file, we remove the broken file, and then after removing the broken file, you can see that the canal of the broken file will also had this kind of S-shaped, and in this case I used Fanta AFF1 Blue file also, because really and honestly these files on such cases or canals will be very, very, very beautiful and helpful. Again, here we have this broken file, and also I did remove the file because I have this patient referred to me. So as you can see in the picture on the left up, we have a broken file and we have a perforation. When this patient came to my clinic, you can see here how much bifurcation radiolucency you can see in the preoperative x-ray because of this kind of perforation, because the patient, the previous dentist tried also to remove the file and he shaved a little bit more, but he was not able to remove it, and then he decided at last to refer the case to me. Then, as you can see, with ultrasonic, Ultra X, I just were able to remove, yes, it's sandwich technique, to remove the tab of the file, and then after that you can see that the two canals are opening together. I just obturated the canal without a perforation, and then I put my master cone in the canal, the other canal, and cut the getaberca in a deeper level than the perforation, then put MTA in the area of the perforation, and the area of perforation was a little bit coronal, so I just obturated the whole canal after getaberca with MTA, so it's not a sandwich technique. If you want to consider it a sandwich technique by composite out in the coronal or in the axis cavity or in the bulb chamber, it will be a sandwich technique. You can consider it a sandwich technique. Alright. And also here we have this kind of file. It was deep inside the canal, but with very, very, very conservative preparation. I was able to just use my Ultra X and my BTR pen, and you can see, maybe you think that this is not conservative, but I will just to show you the obturation. What do you think? In the mesial root, in one of the mesial canals of the mesial root, and I can remove the file and I can obturate after that and save a lot of dental. So, as I told you, from my protocol with ultrasonic Ultra X and with the BTR pen, you will just do most of the cases in your clinic. Here we have a case. This patient is a dentist, by the way. She came to my clinic and she told me that she made this preoperative x-ray in our endodontic department in Cairo University, and they told her that this case needs apical surgery just from the x-ray. And then she came to me. I just made the preoperative x-ray and I told her I will just open and see. Then after I just opened, removed the cotton pellet, removed the temporary restoration, I found the file very loose. I just removed it or catch it with the tweezer. It was very easy. So why to go to a more advanced pre-apical surgeries if you can just remove the file very easy? I'm not against apical surgery. I do a lot of apical surgeries, but in the right case that needs apical surgery. And then after that, after I remove the file, I could be able to negotiate an apical split in this canal, and here is how I put my master cones, and here is a apical split you can see, and then after the apical split, and here is obturation, and you can see the apical lesion, very big apical lesion. And by the way, people told me this case will not live, this case is a little bit destroyed, this case is a little bit not restorable, and here I will just show you 1 year follow-up. Look from the left to the right. After I finished it, I put a fiber post, and then I put an Emax crown with a vertebrae technique. And you can see complete healing, I hope. Complete healing. The lesion went out, the lesion disappeared, everything's fine, everything's perfect. The patient bite, or the dentist, because the patient, as I told you, was a dentist, bite on her tooth and touching wood, thanks God, everything's fine, everything's great. And here is the last case. In this case, I did bypass the file and then by luck it was removed. You can also, not by luck, you can also, as I told you today, put a smaller size file, K file, on the endoshock of ultrasonic and to remove it, to try to vibrate a little bit with the EDTA solution, and you can remove the file. I hope that I changed your concepts now or today about retrieval. Retrieval is a great, catchy, one of my favorite topics. But you have to know that it has a lot of things you must have. Great magnification and illumination, indeed, that will be abbreviated in a microscope, operating microscope, and also the right techniques, the right conservative techniques. Ultrasonic, nowadays, Ultra X really give us this kind of conservative smaller tips you can use, and also the PTR pen, the very good, with a great lifting capacity wire and their very conservative needles. So, as I told you, ultrasonic Ultra X and BTR pen are my weapons in my clinic. And then after retrieval, my great weapon is Fanta AFF1 Blue. We finished today our lecture. I will just take 2 minutes break and then I will answer all the questions. Please just write all the questions and my friend Ansel will just send me the word of all the questions. And again, I have to mention that without this coronavirus, I was supposed to be in my favorite city, Kielce, in Poland today. So I have to say hi to all my friends there, and I will just take 2 minutes break. Alright guys, I'm here back again. We have a lot of questions that ask about what kind of tabs I'm using with Ultra X and what size, what power. Alright, I will just give you a hint about the tabs I use and what kind of tabs, what size and what power. First of all, Ultra X has 3 tabs. They have silver, they have the gold, and they have the blue one. The gold one is the most stiff one and the most aggressive one that you can use to remove the dentin. The silver one is a little bit flexible and you can use it in straight canals. And the blue one is a little bit very flexible to be used in the activation of curved canals. So for me, I use the gold and the silver more probably in retrieval. But I have also to tell you that I use the blue one in retrieval and it was really great. By the way, the video I made here, the live video, the live demo of the broken file removal was with the blue one, and it was in a block, plastic block, and you know that the plastic blocks dampen the ultrasonic taps and the ultrasonic energy, but it was really great. So in this case you can use the silver tab or a gold tab from the Ultra X. What kind of size? They have 2002 and they have 2502. I think they are the same. If you want to be more conservative, you can use the 2002. Alright, just 1 second guys, because I have to catch this thing and I will be back in 1 minute. I'm so sorry guys, I'm here back again. So as I told you, you can use the gold or the silver one. And even the blue is not bad, but the gold and the silver is a little bit stiffer and better to be used in ultrasonic troughing or dentin troughing around the instrument or the separated instrument. Dr. Muhagad is asking who is the one on the door. It's this information is highly classified. I cannot answer you. All right, again, and the size, as I told you, is 2002 and 2502. You can use either of them. For the power, I will just tell you a catchy tab, catchy secret. They have 2 powers, higher power and smaller power. You can use the smaller power when you are touching the file, and you can use the higher power when you are removing the dentin. So first I use the higher power to remove the dentin a little bit, and then when I start to touch the file or do this troughing or just this kind of soft contact to the broken file from the inner curve, I use the lower power. So higher power for dentin, lower power for the file. Alright, this is about Ultra X, and this is about how to use Ultra X and what kind of tabs and the power and the size. For the BTR pen, I always start with zero point 0.3 because, as I told you, I know that they have 0.4 and 0.5, and it's a little bit fine in the straight or big canals. But as I told you, I use this kind of conservative coronal preparation, so zero point 0.3 is fair enough for me. That's it. Any kind of other questions? I will just check. Someone is asking me here, after bypassing, if we don't have, I was sure that this question is Egyptian. if we bypass the broken file and not have a microscope, is there any technique that helps us in retrieval of these files? All right. You can just try, as I told you, the Endosharp with the smaller size K file, and to just try to vibrate the broken file. But I have to tell you that you may take the file out or may push it more deeper. And also, using the ultrasonic with files is a little bit a technique I don't like, because sometimes the tap may be engaged in the apical part or the smaller apex and or the smaller apical constriction and can be broken. So that's why I don't like to use it. And also the braiding technique, as I told you, you can just use 2 or 3 files and try to remove it, but the file must be loose in such case. And here is a Dr. Dugan, I think he's Turkish, and he said that looks like we have to refer our patients. It's not a problem. By the way, I have to mention this. When I didn't have a microscope in the first days of my practice of endodontics, I didn't have a microscope. And just one second. And I did break a file because we are all prone to broken file, as I said. And I did break a file. And I was not able to remove it indeed because I didn't have a microscope. And then I take the patient and take him in my own car and go to my friend that had a microscope, and he removed the file, and I did pay to my friend because it's my problem. And this is not a bad thing to refer cases to the guy that had the appropriate tools and appropriate techniques to remove the file. So yes, refer the file. We have to learn this concept of referring the patients to the right guys that can remove the file. It's not a bad or shame thing to do at all. All right, okay. Any other questions? I have to check. Please, guys, stop these comments. I cannot see the questions. It was super informative. Thank you, Dr. Golaya, and useful. I thank you for the lecture. It's probably to remove a broken file from the apical part. I cannot see the question anymore. Without a microscope, if you perform all the steps in true sequence, no, Dr. Golaya, please do not remove any file in the apical area if the canal is not straight. And here you ask if you don't have a microscope. No, indeed no. Do not even try to remove a file in the apical area without a microscope. It will be catastrophic. Just like the case, the premolars that I showed you for the dentist, and he tried to, and by the way, he is also my friend who tried to make this blind refining, but it was a little bit catastrophic. So please do not try to retrieve a file in the apical area without a microscope. Any other question? Right, these guys, if you have any questions, just write it. We can try to remove a broken file at the middle third If we only have a loop magnification of 3.5, it will not be easy at all. I'm telling you that it will not be easy at all. And because it's not just about magnification, 3.5 magnification is very small, very, very low, and also illumination will not be very fine, very good. So it will not be easy. Should the separated instrument be loose before using BTR pen? Here is a starting of good questions. Dr. Abdul Halim, he's a great dentist, by the way. He asked about if we should loosen the file first before using BTR pen. No, and this is a surprise for you. I do not wait for the separated instrument to be loose, because sometimes the broken file or the separated instrument may be broken due to torsional fatigue, and the tip will be engaged a little bit inside the canal, and if you have a longer file it will not be dancing or loose easily. And I'm telling you that BTR pen can remove the file even if you have this coronal exposure for 1 or 2 millimeter without even the file is starting to be loose inside the canal. Any other question? How not to overheat the ultrasonic taps? Dr. Stanislav. Alright, you can just use the lower powers, but if you are using the lower powers, it will not remove the dentin in appropriate way. So you can just use the irrigation, you can use this kind of intermittent steps, you can use the ultrasonic without coolant indeed to enhance the vision, and then you can cool the whole system with irrigation and then dry again. And also you can use strobe cool. If you have strobe cool taps, you can use it also to decrease the heat a little bit. But for me, I just cool down the whole system, add in nuclear reactors, and again to dry and use it again. What other question? How about 6x magnification, doc? Is it good enough? What about someone will tell me 7x magnification, 8x magnification? I need to tell you, in some microscope, in some operating microscopes, 6x magnification is the first step in microscope. I know that a lot of people don't have a microscope, but in retrieval it's a little bit a must, guys. 6x may help you indeed, but you will not be conservative as the one with the microscope. Alright, here's my answer for this question. Dr. Dveki Sityapikti, I hope, or Shityapikti, I hope I read your name in the right pronunciation. But 6x magnification, yes, you can, maybe you can retrieve the file in the middle third, but you will not be conservative as the one with the microscope. That's it. Another question from Hard Work. Can you use Ultra X in a wide canal? Indeed. It will be very, very easy to use. Very easy to use. Any other questions, guys? Grating from Mexico. Yes, as I always say, grating from Egypt to every single country. And by the way, I did check the countries that are here in our group, and we have a lot of Mexican, great Mexican dentists here, and we have a lot of Polish friends, Albanian friends, but the main countries are Egypt, Iraq, Turkey, and Syria. The bigger number are from Turkey, Iraq, Egypt, and Syria. And also, I have to say hi to the great beloved country to me, Palestine. All right. Can Ultra X compatible with other brand tips? Unfortunately, no. Unfortunately, no. Ultra X is not compatible with other brand tips, and by the way, the tips are very cheap. And Ultra X, even it's about 200 euros or something like that. I should not talk about that here. And we have Canadian dentists here also. Ratings from here. Is ET's Ultra X compatible with other? I answered this question. And thanks for great lecture. Thank you. You are welcome anytime. It's okay indeed. Any other question, guys? We still have 10 minutes for questions. Can we use for this case? I'm just waiting for any questions. What is the best fluid to be inside the canal during retrieval? For me, it's EDTA solution indeed. Not during the retrieval, but after the file is loose, to remove the file, it will be EDTA solution to help the file or the separated instrument to be flushed outside the canal. But during that refining or during the retrieval technique, I use sodium hypochlorite only. I know that some people use oils, olive oils, and my great friend Yushi Triuchi use olive oil, and he has a great results. But I don't use it. I just use sodium hypochlorite. He uses it, and I think that he has great results. And you can use it, but for me, for Kurdi, I just use sodium hypochlorite. Any Dr. Dewey or DV, Diana Zhang, any comments for BTR pen? More better than N Cowboy, Triuchi loop, same technique. Look, they have the same technique indeed, but in my hands, and I think that everyone knows that the Triuchi loop is a little bit, with all my respect, is a little bit weak, and it's a little bit easy to be teared or to be broken easily. So, if we are going to compare, we have to remove Triuchi loop from our comparison. Then it will be the bigger comparison between BTR and Endo Cowboy. Look, in my hands, BTR is great, and BTR I can do it. I can do everything with that, and I have to tell you this exclusive surprise, because some studies are in their way to compare between them in an evidence-based way, and I don't have to tell the results now, but BTR is great. I hope that is enough for you now. Any other question? I think, yes. Dr. Yugin Chan, what is your thought on using modified high suction tab to retrieve the file after the file is loose from the ultrasonic? I'm not against indeed. If you can use it, it will be fine. I'm not against that at all, because I know that, by the way, we have some future attempt to remove the file. For example, they started to, tried the electromagnetic waves. They started to melt even the file inside the canal. Nowadays, they want to use laser also. But I'm telling you what I'm using in my clinic nowadays, and I hope that in the future they will just give us more predictable ways, and indeed I will keep you all updated about that. But I have to tell you that the best way to retrieve a file is not to break the file from the origin. That's why I'm telling you guys that I don't have a lot of retrieval of my own broken files. I always, or more commonly, have referred cases of broken files or separated files, because single use will be great, and thanks God we have a lot of great files nowadays, which is not very expensive and very great in cutting and flexibility, like the Fanta AFF1 Blue file. So please do not use the file more than one time, and it will not break. So you will not have to retrieve files unless you have referred cases already with broken files. All right. Thank you, Dr. Peter. Super informative, perfect, and to the point as usual. Thank you so much. That's what I always hope from my lectures, to be to the point, to give you the right tips and tricks to be used in your clinic. Any other questions? And we have Dr. Osama Hitmi from Morocco. Ratings from here to Morocco also. Dr. Melis Oya Atish. I hope I pronounce your name right. Another question. Which movement can we use when we use BTR pen for retrieval? This is a good question. Dr. Amira Adil. Great question. Once you engage the broken or the separated instrument, you can just make some buccal and lingual, mesial, and distal movement just to move or to hesitate the file or to vibrate the file a little bit and then to pull the file. Thank you so much once again, Doc. See you in the next lecture. Can't wait it. Thank you, Dr. Dveki or Dweki. Have you tried the vertical reciprocation hand base like Endopulse to retrieve the file? No, I didn't use it. I have never tried it. I know that I think that a French company from France have this kind of reciprocating Endopulse, and yes, I think I saw it before, but I didn't use it. I didn't use it before. The idea, I think it will be a little bit the same like the using the K file with Endoshunt for the ultrasonic, but it may be more conservative and more predictable in removing the file. But I'm trying here to mention the most effective reproducible techniques and instruments, and also not very expensive, because we have a lot of expensive instruments, but I don't know if it can be used in a reproducible, repeatable way in our clinics. Any other question? I think that everything's fine. Dr. Isra Olokoyolo, you are the best. Thank you, doctor. Any other question? I hope I did answer all the question. And one question I have to answer also: if the file is above the curve more coronally and I cannot make retrieval, can I make bypass? Why you cannot make retrieval? Because you don't have a microscope, you should refer it. You don't have the right tools, you should have it. You don't know how to do it, you should practice even an extracted teeth until you do it. As I said, if you have a file, if you have a broken file coronal to the curve or before the curve, the best way is to retrieve it. And as I said, as long as you can retrieve the file, as long as you can remove the harm, it will be better for better cleaning, better shaping, and better apical seal and obturation. I think that by answering this question, we finished our lecture today. In the next Sunday, we will have the last lecture about non-surgical retreatment and all the great files of retreatments and all the retreatment techniques and retreatment options, and how to remove the Gutterberg, how to remove the post, fiber post, whatever the post. We will talk about all that in the next lecture. Hope you are doing okay. Doctor, personal question. Are you doing okay in this COVID crisis? Thanks God, I'm fine, and I think that everything in Egypt is under control and everything is fine here. Thanks for your question. Thank you so much for your concern. And again, I'm really happy that we have all these attendees here in our webinar. and see you all next Sunday. Thank you so much and see you all. Bye bye.